Okay, so we still have a few more people who are joining, but in the interest of time, we're going to go ahead and get started. Welcome to our second National Neonatal POCUS Collaborative webinar. Just so everyone knows, the chat function for this webinar is disabled. Please use the Q&A feature to post any questions, and then we will answer those during the Q&A session. All right, so Dr. Ben Kozyak is a cardiac intensivist at the Children's Hospital of Philadelphia. He heads the point-of-care ultrasound program in the CHOP CICU and is a leader in the application of POCUS and pediatric cardiac critical care nationally. Recognizing a problem in the high rate of UVC malposition in neonates requiring cardiac intervention, he developed a technique for real-time ultrasound guidance that markedly improves success and has generated significant interest amongst both neonatologists and cardiac intensivists. Dr. Kozyak is also pursuing several pediatric device development collaboration, and he serves as the Associate Director of the Advanced Cardiac Therapeutics ICU, helping to guide the management of children requiring mechanical circulatory support. We are so grateful to have you here today, Dr. Kozyak, and we'll turn it over to you.
Hi, can everybody hear me?
Yes, we can.
Okay, awesome. Let me just get these slides into share mode, and then we'll be off and running. Is that working okay?
Yes, yep, looks good.
Okay, great. Let me know if there are any IT hiccups or anything along the way, and we will. We can always just pause and address them. An ultrasound over IT can sometimes be a little choppy, but hopefully this will work fine. Anyway, hi. I am. Do you guys know? Is there any way to every time someone joins the lobby, it's dinging? I don't know. Is that coming through your? Is that coming through on the audio, or is that not a problem?
I don't think that we can hear it on your audio. I don't think.
Okay, as long as it's not.
Yeah, I can hear it, but I don't know if everyone. So I don't know how to do it. Keep going.
That's okay. Okay. So, all right. Hi, everybody. My name is Ben Kozyak. I really appreciate the opportunity to talk with you guys today. I'm one of the CICU attendings at the Children's Hospital of Philadelphia, and where like I said, I'm not a neonatologist, or like y'all said, I'm not a neonatologist, but I have loved collaborating with neonatologists both at CHOP and elsewhere on this project. I do take care of a lot of newborns, and so this was a technique born out of that, and an attempt to get the kids, the babies that we take care of, the access that they need. I have no disclosures. I think y'all don't need any introduction to this concept, but just briefly, I think we're going to talk in terms of an outline, we're going to talk about why umbilical venous cannulas are great, particularly in the preemie population and the cardiac neonates, especially where PICCs aren't readily available. That can be pretty variable depending on what center you're in. Why UVCs have a frustratingly high failure rate, and then how to apply a novel POCUS technique to address these problems and achieve successful central UVC placement. I think most of you are familiar with radiographs that look like this. Central venous access is pretty essential to the resuscitation of the critically ill neonate. UVCs are the most widely utilized central venous catheters perinatally across the world, but unfortunately placement has a success rate of only about 50 to 75%, even in the hands of experienced neonatologists. I'm sure you've all been there at some point, attempting over and over again to advance a catheter that keeps getting stuck in the liver. You push on the belly, you feed the line in and out, you try a variety of different things, and then, eventually, mutter something under your breath that you probably shouldn't say in front of a baby, and then give up, not really sure why you couldn't get it to go. And we're going to talk about figuring that out, and then using this technique to address the problem and hopefully get rid of some of that frustration. So here's a set of illustrations overlaid on radiographs to illustrate the passage of an umbilical venous catheter. On the left is the desired position. The catheter comes up from the umbilicus, takes a turn through the ductus venosus in the liver, and then into the right atrium. In the middle, the catheter is tracking off into one of the left portal veins. And here on the right, it's tracking off into one of the right-sided portal veins. The other structures labeled here include, so here's the umbilical vein, here's the portal sinus, which is sort of a portal confluence between the right and left portal veins, and the ductus venosus, which is here. Here you have the hepatic veins coming into the floor of the right atrium, and the so-called subdiaphragmatic vestibule, where all that comes together into the bottom of the atrium. So the catheter can get stuck in the right-sided portal veins, or on the right-sided portal veins here, or the left-sided portal veins here. And I want to just call attention to one more thing before we move to the next slide, and that is that a lot of people see X-rays that look like this and think that the catheter is in the ductus venosus, but just a little bit short. Because, if you compare this panel to this panel, that makes sense. But if it doesn't go up above the diaphragm, you got to really be careful, because this is actually lodged in a left-sided portal vein. It's just as bad as this. And if you start infusing, potent stuff through there, TPN, epi, etc., it's gonna cause a problem. So this is not just a didn't quite make it version of this. It's actually in the wrong place. And ultrasound can help you figure that out when you're not sure, because those can look pretty similar. So here's another representation of the anatomy, demonstrating that it's not, literally speaking, as straightforward as we would like it to be, or as it looks by AP radiograph. This Gray's anatomy plate on the right is neither straight AP or lateral, but sort of has the liver flipped out. And I think it does a reasonable job of showing how the anatomy that we're interested in, and how the catheter needs to navigate that anatomy to get it to where you want to go. So here's the umbilicus here. Here's the umbilical vein superficially. And then it dives into the liver, as you all know. It picks up branches of the left portal veins first, and then eventually also joins with branches of the right portal vein. All that blood makes its way through the ductus venosus. Well, some of it goes into the portal veins, and some through the ductus venosus to the IVC in the heart. So really, what you need your catheter to do, what you're asking your catheter to do, is go up the front of the belly like this, and then dive down into the liver and not get stuck here, not get stuck here, not get stuck here. This one's always a huge pain in the butt. Not overshoot and go here, but instead go make this S turn through here, and then up. So it's sort of a wonder that it ever goes, where you want it to. I think these angiograms sort of illustrate that another way. So these are cath lab angiograms taken by injecting contrast into a low UVC. So again, here's that same illustration we looked at earlier, and here's an AP angiogram and a lateral angiogram that shows what happens when you inject contrast. So if you inject contrast here, the lateral I think is more informative. What needs to happen is your catheter, had it gone into the right spot, would have to go through here into the portal sinus, not get stuck in any of these side channels, and make it out the back into this ductus venosus, and then up here sort of obliquely cephalad and posterior into the right atrium. This is a 3D rendering, or a volumetric rendering of a contrast-enhanced cardiac MRI that I think is also informative with respect to the anatomy that we're talking about. And so we'll walk through it. But basically, you can see the heart here, and you'll see the cava coming in, the aorta behind. And as it plays and rotates, you'll see what I'm talking about. I'll kind of pause along the way and cut in and out of the video. So we're going to spin that lat into a lateral orientation. So now posterior is towards the left and anterior is towards the front. And now we're just going to cut into this anatomic model. This is a vascular shell model, so the vasculature is hollow, and I'll just pause it right there. And so what you see here is the aortic arch coming off the left ventricle with its branches. And if I back it up, you'll see the aorta. And then if I go a little further to the right, you'll see the vena cava here, SVC, IVC, right atrium.
So Ben, I think you are one slide behind. I know which one you are actually meant to be showing. We are seeing the 3 X-rays with the.
You are?
Yes. So I think there is a
Oh.
little bit of delay. Just go to the one you are explaining.
Sure, thank you.
Yeah.
It's on my screen. It looks okay. Maybe I should pull it up on my phone also to monitor what it looks like to y'all.
That's crazy. So do you want to unshare
Yeah.
and share again? Because I mean, I'm just chatting with other people.
Let me see. I'll go back and forth. Did that pull it up there?
Yeah, no, not yet.
Well, this
I don't know
video,
why.
it's okay. I can.
There you go. Right. This is the heavy video. Okay, now now we see it.
Now it's up. I wonder if it just takes a second to load because it's a heavy video. Okay, thank you. I'm gonna put put it as like my own little monitor on the on my phone here, and just with the sound off, and just so I can see what y'all are seeing as well. Okay, great. So, all right. So so what you see here, yeah, it's still playing, but sort of delayed. Okay, so maybe I'll just it's still sort of showing. Okay, I think it's caught up now. Let me see. Okay, good. All right, great. So can everybody see that? Maki, looks okay?
Yeah, now we're seeing a lateral cut. Yeah, sagittal.
Okay, great. So here's the aortic arch coming off the heart, right? And now it's going to start playing through. All right, so now this is just playing through it now that it's finished caching it up, I guess. And so it's going to cut into the heart. This is in a lateral projection with anterior to the right. And we're going to cut in. You see the SVC, IVC there, and then the aortic arch there. And I was just going to pause it because the structures that we're looking for are down here in the liver. So here is the IVC coming into the right atrium. There's a big hepatic vein coming into the right atrium, and here is the portal, one of the larger portal veins, and this is the ductus venosus, this little guy right here, coming up from the into the liver. And then we take the soft tissues off and just show you the vascular shell model. Again, what it looks like is, I was trying to, it's not coming through the way one. I'm just going to skip on, but basically what I was trying to demonstrate with this is just that it's quite a small connection between the umbilical vein and the ductus venosus. So, or in between the ductus venosus and the heart. So let's skip ahead to the next slide here. Is this working for everybody? Do you see the baby?
Yep, looks good.
Okay, perfect.
Yes,
great.
Okay.
All right, great. So here's how you do this. So you position the baby supine with a small bump under the hips that helps sort of angulate things in a favorable way, I think. So we've got a small towel roll under the hips, and then the arms and the legs sort of swaddled out of the way. Diapers for this and a blanket for this. And the babies actually seem to like this position, and they chill out, and particularly in the first day of life, and kind of let you do what you need to do. As far as the ultrasound probes, I don't have any affiliation with any ultrasound vendor. These are just example images. But I think a linear probe, a larger format linear probe for a term baby, or a smaller sort of hockey stick style linear probe for a preemie works very nicely because it offers you both spatial and temporal resolution. Even in a term baby, a probe like this can really see through the entire baby. and sort of get you the imaging you need sort of all the way through the liver down to the spine. And it allows you to see all the, and it has a pretty wide field of view. This covers sort of, most of umbilicus to subxiphoid in a little kid. So this is my go-to probe for this procedure. Although prior to getting started, I think it's really important, and we'll talk about it in a second, to confirm that the ductus venosus is actually patent. And for that, this phased array probe or cardiac style probe is very useful. So what you do is you situate the baby, place the ultrasound probe in the midline, subxiphoid, and oriented sagittally. This larger linear transducer, as you can see, takes up a relatively large amount of real estate, which is good because it provides a nice wide field of view. And for preemies, a smaller transducer might be more appropriate, of course. So then if you think about the orientation of the anatomy, the umbilicus is a midline structure, right? And then the IVC and right atrium are slightly right of midline. So you sort of need, so the imaging plane that captures most of this is rotated slightly counterclockwise off the sagittal. And then often sliding a bit to the patient's left, and then tilting the beam back to the patient's right brings the anatomy into view. In some patients, you end up finding that the best view is sliding slightly to the right and angling back to the patient's left. Every patient's anatomy is a little different, and so you just have to make small adjustments until you get the view that you want. As each patient, it is slightly different, but really starting sagittally, subxiphoid with a little bit of counterclockwise rotation helps a lot, and then sliding to the right and angling the beam back to the left, or vice versa, until you get the view of the ductus venosus coming into the right atrium. I'll show you what this looks like. So for orientation, I'm superimposed the ultrasound images on this lateral radiograph. The relevant anatomic structures are going to be labeled here. So there's the heart, right? The diaphragms, the endotracheal tube, the umbilicus is up here. The umbilical arterial catheter is here in the descending aorta anterior to the spine, and we'll talk about what that looks like by ultrasound in a little bit. And then the umbilical venous catheter is here, coming in and then taking a dive through the liver and then into the heart. So when you put an ultrasound transducer on the abdomen in that sagittal orientation, you get an image that looks like this. So again, a little bit of scooting back and forth, very small rotations until you get something that, to optimize your image. But once you get it, if there's a catheter in place, you want to be able to get an image that looks like this. And what you see is the umbilical, this is the portal sinus, or that portal venous confluence. And then the catheter comes in through that into the ductus venosus, often straightens that out a little bit in the process, and comes into the bottom of the right atrium. This is that large hepatic vein that also comes into the to the bottom of the RA. Like I said, before you start this procedure, it's important to make sure that the ductus venosus is patent. My two go-to ways of doing that are color Doppler and then also agitated saline contrast. When you turn on color Doppler, you can get an image that looks like this. So then this is blood coming in through the coming down from the hepatic vein into the floor of the right atrium, and here's blood from the portal sinus. Also making its way into the ductus venosus and down into the heart, and it'll sometimes be a little bit bidirectional as there's reflux from the atrium with atrial systole. And this is what it looks like when you inject agitated saline into that low-lying UV. That catheter is up in this vicinity. An injection of some agitated saline contrast or some blood saline admixture gives you a nice contrast look. And you can see here that the ductus venosus is patent and connects to the portal sinus, and that's what you want to know, so because that's where you're going to be putting your catheter. So the setup looks kind of like this. So again, the baby's under here. Umbilicus is over here, the head's on the left of the screen, and I set up the ultrasound machine so that I can work across the baby. I'm right-handed, so I like having the probe in my left hand, and I'm manipulating the catheters with my right hand. And I know some people are very, prescriptive about where the dot goes. for this, I mean, the dot goes wherever it makes sense. I usually put the dot towards the head in this orientation, but if you're lefty and you're doing it from the other side of the baby, of course, you know, flip it around as you need to so that it makes sense. You'll notice that in this image, we have the same person doing both the imaging and the catheter manipulation. Some people like to do this with two different people, whereas one person is manipulating the catheter and the other person is imaging non-sterile under the drapes. I find that harder to be honest, because you know your left hand knows what your right hand is doing, and you can therefore see where you need to make adjustments and make those adjustments rather than trying to tell another person, you know, image a little bit this way or a little bit that way. And also, if you prep the baby widely from basically you know, hips to nipples and across from one mid-axillary line to the other, you have a nice wide sterile field. You can image freely with the probe, with a sterile probe cover, and get really nice pictures without worrying about contaminating your sterile field with gel from a non-sterile imager. So anyway, that's the way I approach this, and so far it's worked out pretty well. So this is what the procedural image looks like. Again, this is in a sagittal orientation. In this left panel here, you see the umbilical venous catheter in the umbilical vein at the top, coming in here into the portal sinus. Those arrows show you where that catheter is, and the tip is actually here lodged in this portal vein. One thing to point out is sort of how to distinguish portal veins from hepatic veins. You'll notice that this portal vein here has a very echo bright endothelium. Can you guys see where I'm indicating with the laser pointer? It's kind of all over the place. I wonder why. What was with that delay? Can you guys?
Yeah, the pointer has been delayed. It's been behind. Yeah, you may use your labels.
I'm trying to. Okay, well, you'll see where the umbilical venous catheter tip is in the see it there? That's the portal sinus, and that is that's the left portal vein, and you see that the endothelium is pretty echo bright. I'm gonna flip screen to another back slide and then forward and see if it can. It's this delay, but what I was trying to illustrate is that this has an echo bright endothelium here, and the hepatic vein, by contrast, has a relatively indistinct epithelium, as you can see labeled HV on the right panel. Hey Maki, what do you think? With the delay, should I just back out of this and then share directly from my desktop? Do you think that would be would that be better?
If you wanna try that, sure.
I mean, why not, right?
It will take a second. Yeah, there is a delay on the pointer, for sure. Okay, give it a try.
Okay, I'll give it a try. If it doesn't work, it doesn't work. Okay. All right, let me just get to the slide that we were on. Okay, is that sharing now?
Yes, we're seeing the baby with the transducer.
Okay, great. So we'll hopefully be able to, the videos will play smoothly this way. So that's where we were. Okay, so now hopefully there's less lag on the, it's still a little bit laggy, but you see the, all right, you see here the left side of portal vein. This catheter here, designated by arrows, has its tip in the left portal vein. And the thing that I wanted to point out here with the left portal vein is that the endothelium is sort of echo bright. That's different from the hepatic vein over here, where the epithelium is pretty indistinct. That's just one way to distinguish the structures that you're looking at. So what's happened here is this UV catheter has come in and then gotten lodged in this tip of the portal of the has its tip lodged in the left portal vein here, where you would have ideally liked it to pass down down through here. So the in the right panel here, you can see the catheters come all the way through the ductus venosus and into the floor of the right atrium. So I'm going to show you how ultrasound now assists in navigating the path through the portal sinus and into the ductus venosus. So here you can see the left portal veins, the right portal vein, and the ductus venosus. And I'm just slowing down how fast I'm talking so that the pointer keeps up. But what I also want to point out here is that it's hard to catch all of these structures in exactly the same plane. The left here you see the portal sinus really nicely, and the and a couple of left portal veins, and the right portal vein, which is actually behind this shadow and kind of going off the side of the screen. But you don't see the ductus venosus. Here you see the ductus venosus and two left-sided portal veins, but you don't see the right-sided portal vein. So what happens here? So what you want your catheter often wants to go here, or it wants to go down here, or it wants to go this way, but you want it to go this way. When you apply gentle pressure with your ultrasound transducer as you're imaging, it does several things. It compresses the orifices or the entrances to these left-sided portal veins, which makes it harder for the catheter to go in. It makes this angle into the right portal vein less smooth and more of a sharp turn. And it also aligns the portal sinus and the ductus venosus, making it easier to insert your catheter. So I'm going to show a few very brief videos of the technique in action. They're going to show you, we're going to talk about the relevant anatomy, how to assess patency of the ductus venosus, and then we'll move on to some procedural videos showing you how to actually manipulate the catheter. Hopefully this will work smoothly. If for some reason it doesn't, please let me know, and I will just back up and restart. This looks, so there's, Maki, how does it look here?
It's fine. Now
Okay.
it's fine.
Okay, great. So what I'm going to do now is turn on color Doppler and show that there's flow coming in through the ductus venosus. Then here we're going to inject agitated saline and again show that that structure is patent. So you see there is agitated saline coming from the portal sinus through the ductus venosus and into the right atrium. That came through reasonably clearly?
Yeah.
Okay. In the next video, I'm going to talk about the most common reasons for catheter malposition. You'll see the umbilical venous catheter caught in the left and right-sided portal veins. So here you see the catheter caught in the left portal vein. That's the same image we looked at the beginning. And here you see the catheter caught in the left portal vein by ultrasound. The catheter is highlighted in blue and the left portal vein in pink. Once you start moving the image, what you see is that catheter is off there in the left-sided portal vein, whereas you'd wanted it to go, down through the ductus venosus. Here it is in the right-sided portal vein. Again, that same image, that same illustration we saw at the beginning. And here, I'll pause the video for a sec. You can see the catheter coming down and through, and the ductus venosus is over here, but the catheter is bypassing it, and it actually goes off the screen into the right side of portal vein, which I'll show you. So there's the right portal vein. There's the catheter. When you move your ultrasound probe further over to the right side of the patient's liver, you'll actually see where the catheter ends up, deep in the right portal vein there. Again, I'll highlight that in pink. There's the right portal vein. There's the catheter, way off where you'd intended it to go. All right. This next video is going to show you what titrated liver pressure can do for the anatomy. So this is accomplished using one's imaging hand and the probe itself in order to improve the alignment of the vessels, which facilitates cannulation of the ductus venosus. And as with any ultrasound guided procedure, it's it's important to keep track of the catheter tip. So here you see that sort of same image, and I'm going to pause it for a second and back it up. And what you see here is the umbilical vein at the top, the portal sinus here, and then the ductus venosus here. And what's going to happen is you're going to see the anatomic sort of arrangement of these structures change when we push a little bit on the liver. So this is the same technique that you use when you're trying to place these blind. You're pushing on the liver and trying to see what, and hopefully hoping that it helps the catheter go. This is what's actually happening with those vessels, and why that technique, has been an important troubleshooting maneuver for years. So you can see with a little bit of titrated liver pressure how all those structures sort of flatten out. So there it is by itself in native configuration, and there it is with a little bit of liver pressure. Again, before and after. And here's what it looks like when the catheter makes its way through. So again, the catheter could go that way. You wanted it to go that way. And so you put a little bit of pressure on the belly with the ultrasound transducer, compress things a little bit. The orifices to those portal veins are less favorable, and the catheter slides through. So there's the before and after representations of the anatomy. And then here's what it looks like when the catheter slides through your improved aligned, vessels with improved alignment, and goes where you want it to go. Very satisfying. Here it is in another patient, and you can see the tip coming through into the bottom of the right atrium there. And then you figure out where you want to leave it and site it. I have this and site it there. I had that last frame there to just show you that, and we'll talk about this as well with umbilical arterial catheters, that the catheter, you see it here in the ductus venosus, and then as it goes into the right atrium, you see that shadow there, you see that catheter artifact, but you sort of lose it. It's much easier to see where a catheter is in a two-dimensional vessel than in a three-dimensional structure, or a sphere, so to speak, like the right atrium. So the best thing you can do is find the tip as it's coming through and follow it to the low right atrium, and then park it there, rather than try to figure out where it is after it's already deep in the heart. But many of you will be using this technique for confirming position of umbilical catheters placed in sort of the traditional manner, and for that, it's you can see, you can't always tell exactly where the tip is, but but you can tell whether it's in the right place or whether it's off in a portal vein, and it's it complements the radiographs nicely. Sorry, this rewound to the beginning. So I just wanted to show you were about here. So again, the catheter slides in, and then you park it right there. This is another patient in whom we're doing the same thing, and then these are before and after radiographs. So that was stuck in the left portal vein and then retracted and placed correctly into the right atrium. Ultrasound can also be used to inform other maneuvers that we've often used as troubleshooting techniques over the years, like dual catheter or line over line techniques. I'm sure many of you guys have done that in the past. You can do that with ultrasound as well, and you'll see here why it works as well as it does. So in this patient, we'd had a prior blind attempt at an umbilical venous catheter placement, and it was kept catching in the left portal vein, so it was left low. And here you see the catheter getting stuck in that left portal vein. It's really it was an ongoing problem. This was by far the easiest place for the catheter to go. You can see this sort of very wide mouth portal vein, and you wanted it to, whereas you'd wanted the catheter to go down this way. The conventional teaching that larger catheters are typically better because they're stiffer sometimes that's true, often it's true, but it's not always true, especially if you need your catheter to make a turn that a stiffer catheter doesn't want to take. And in this case, a flimsier 3.5 French catheter was able to make the turn, particularly after we left this 5 French catheter in place to plug up this problematic hazard here. And so that is, and that's what I'm going to show you as we continue the video. So that catheter kept getting stuck there, and rather than pull it out and then then try again, we left it in place, and that made it harder for the second catheter to come into this, to get caught in the same location. And what you're going to see is that a second catheter is going to be brought up behind this one, and then down through the ductus venosus and into the atrium. So here you go. So here's that first catheter left there, and then here's a second catheter brought up behind it and cannulating the ductus venosus the way that you want. So that's a good example of how to use dual catheter technique informed by ultrasound. You're going to laugh at this radiograph because the catheters are all way too deep, but that was deliberate. You want your once you've gone through the trouble to do something like this, you certainly want to make sure it's in. And we also didn't want to accidentally take out the second correctly placed catheter when we removed the first. So we deliberately put this one sort of deeper into a left portal vein, and we deliberately put the second one deeper into the heart than we might have otherwise. And then we retracted this one. And then this one with ultrasound guidance, watching this one the whole time by ultrasound to make sure we didn't accidentally pull it out. So there, the first catheter was removed and the second one retracted a little bit, and then we dropped that one down under ultrasound guidance to where we wanted it, and confirmed with ultrasound. You can also use a similar technique to assess umbilical arterial catheter position. I think we have formulas for this with respect to where the catheter should, what the depth of insertion should be based on the size of the baby. But what you'll notice here is that the catheter just really needs to be, if you look at the ribs, we always shoot for, T7, T8, somewhere in that range, accepting as low as T8, T9. Otherwise, we get worried about mesenteric vessels and pull it back to the low position. But you can assess this with ultrasound too. Really, you want it up here, sort of above the diaphragm and behind the heart. So again, here's that radiograph, right? Here's the heart, here's the diaphragm, here's the umbilical venous catheter that we've been talking so much about, and here's the umbilical arterial catheter here, above the diaphragms, behind the heart. And you can see it here by ultrasound. Here's the UV in the right atrium. Here's the UA in the descending aorta. And here's what that looks like by ultrasound. So let me back up to this image here. This UA is actually a little high, right? It's in the sort of T6 range. And on a prior radiograph, it actually even looked slightly higher, depending on with a slightly different angulation. This is an ultrasound image obtained with a phased array probe over the liver, looking at, so you see the spine here, and the descending aorta is this black stripe just anterior to the spine, with the heart structures here and the diaphragm here. And so when we play this, what you can see the UA bouncing in the liver. I mean, sorry, bouncing in the descending aorta. You see it there with the tip right there? It can be hard to figure out exactly where the tip is, and so it's important to look at it from a few different angles. This is, instead of a subxiphoid, this is a parasternal view. And what you're seeing here is the catheter up behind the atrium, but a little higher than you'd kind of wanted it to be. You'd wanted it sort of just above the diaphragm and behind the RA. This is getting up closer to the great vessels. And here's the descending aorta, but here's the aortic arch, right? The aortic arch coming around, the ductal arch coming in. Here's the aortic arch, and here's the tip of the catheter. You're getting awfully close to the aortic arch in this picture, which is why we wanted it the sort of the T7, T8 range and not in the T5, T6, at the T5, T6 level. But all of that changes, all that can change a little bit depending on how the X-ray is angulated. And so ultrasound does give you some good information that can help you site these catheters. We had a patient the other day where in the cardiac ICU that went for an aortic arch repair, and the surgeon noticed on opening the aorta that there was a contusion on the greater curvature of the arch. The only plausible explanation is that a UA inserted too deeply had banged up against the arch here and caused that contusion. And so I think it is potentially an area where we could use ultrasound to improve our positioning and inform our insertion. Here you see it again, illustrating the purpose of this video here is to illustrate that there's often shadowing in the sort of pleural recess between the liver and the heart, and that can make it difficult to determine exactly where your catheter position is. So you just got to be careful and scoot up and down, look from below and above to sort of get the tip of the catheter out from behind that shadow. Here's a UA in the aorta, in the descending aorta, in a more of a 4-chamber view or more of a transverse view. Sorry, here. See it bouncing around in the descending aorta. So then you can also use this view to inform where the tip is based on where you see it and where you don't. In terms of data, we've continued to do this over the last several years, but we published about 1.5 years ago the results of our pilot study where we looked at 32 neonates with congenital heart disease and malpositioned UVC across 3 centers, the Children's Hospital of Philadelphia, Mount Sinai, and Stanford. These were all cardiac babies. For starters, so they were often term, mean gestational age of 38 weeks, with a mean weight of 3 kilos, although the smallest in the study was 1.2 kilos. And we've subsequently done one as low as 900 grams. I think Alan may have done one even smaller since then. But we've placed them in smaller babies as well. The median age at the time of ultrasound guided umbilical insertion was about 16 hours. And so just to back up here, what we looked at was to see whether we could rescue lines that were placed incorrectly. So babies would be born, line would be placed in the conventional manner. And sometimes it was perfect and sometimes it wasn't. And when it wasn't, we tried to see whether we could use ultrasound to get that line into the appropriate position. So we're not obviously advancing a dirty catheter. We're taking a catheter out, we're re-sterilizing, we're putting in a fresh catheter, and we're doing it with ultrasound to try to see whether or not we could get it. We could be more successful with ultrasound than the first team had been placing it in the conventional manner. And we found that about 72% of the time overall, and 80% of the time in the first 48 hours, we were able to correctly position catheters that had not been correctly placed, in their initial conventional with the initial technique, initial attempt using the conventional technique. I hope that makes sense. What's interesting here is, to me, is that not only were we super excited about the ability to improve our success rate pretty significantly. But we that exact improvement from like a baseline success rate of, say, 2/3 for the conventional placement, increased to north of 90% with if you take 1/3 of the catheters that were malpositioned and you fix, say, 3/4 of them, it gets you north of 90%. And that improvement is essentially the same as what we saw when we started to apply ultrasound to central line placement and arterial line placement in pediatrics in general. So I think passes the sniff test, and we were pretty excited about the results. I'm going to pause there and thank you guys for your attention. I'm happy to take questions, happy to go rewind and go over anything again. Again, thank you very much for the opportunity to all the organizers of this wonderful collaborative. I'm psyched to see what you guys are doing, and look forward to having the opportunity to work with many of you.
Wonderful. Thank you so much, Dr. Kozyak. That was a really, really wonderful presentation. So we'll start transitioning to our Q&A session now. We'll have our panelists turn on their cameras. And just so everyone knows, this webinar has been recorded and it will be uploaded to the Collaborative's website. And the Collaborative's website is www.neopocuscollab.com. It's also as an answer to one of the chat questions or the Q&A questions if you want to see it written out. So coming to our Q&A session, so joining Dr. Kozyak today as our Q&A panelist, we have Dr. Giuliano Ku and Najib. Dr. Courtney Giuliano is an associate professor of pediatrics at Mount Sinai Icahn School of Medicine. She's a steering committee member of the National Neonatal POCUS Collaborative and co-leads the NICU POCUS clinical and training programs at her home institution. Her areas of primary focus within ultrasound are targeted neonatal echocardiography and vascular access. Dr. Jenny Ku is a clinical neonatologist at Sharp Mary Birch Hospital for Women and Newborns in San Diego and an investigator with the Sharp Neonatal Research Institute. She is a member of the Neonatal Hemodynamic Research Center, and she has a special interest in hemodynamics, clinical research, and resuscitation medicine. Dr. Tasneem Najib is an attending neonatologist and professor of pediatrics at Washington University in St. Louis. She is the medical director of neonatal ECMO and the CDH program at St. Louis Children's Hospital and is a member of the CHNC, ECMO, CDH, and POCUS focus groups. Thank you guys all for being here and being our panelists. Our first question that we have is, what troubleshooting techniques have you found to be the most useful? So thinking about when you can't see your UVC, changes in probes, maybe tricks to see the ductus, those kinds of things.
Sure. So I think for starters, the best thing I think you can do to get going with this is to just grab your ultrasound machine and image umbilical venous catheters that are already in situ. So you've got a catheter that's placed that went in the right place or that went to the wrong place, and just see if you can find it, because that goes a long way towards developing the muscle memory. And it doesn't take long before you can see the catheters pretty reproducibly and reliably, but it does take some practice. And so before you've got a sterile field and a time limit, just walk around with your ultrasound machine and take some pictures of some umbilical lines. I think that will go a long way to figuring out how to hold the probe. The main troubleshooting thing and the other thing to remember, I think, that is, important with all of your cardiac POCUS and line procedural ultrasound as well, is that small adjustments make a big difference, right? So sometimes you're talking about rotating the probe 5 degrees or angulating it 10 degrees. You're not, these aren't big adjustments that you need to make. So just be patient and make small movements. The troubleshooting techniques that I have found most helpful, as far as like figuring out where the line is to sort of also remember that, well, let me back up. If you're placing a line with dynamic ultrasound, I don't know what, just to hear what the other panelists think, but I found it helpful to watch the line all the way in from the start to the finish, because then it's very clear. It's very easy then to know when you see it and know when you're not seeing it. if you're trying to do this to evaluate whether a line that's already been placed is properly positioned, then you start to have to use a couple other tricks and like recognize that catheters do things like create shadow artifact and know how to, read the shadows, so to speak. You'll see dropout, even if you can't see a catheter in the ductus venosus, for example, if you're seeing a bunch of dropout right behind that structure, and you can follow it, that's a good sign that, that there's a catheter there, even if you can't see it quite as crisply as you want. Also changing your angle of instination, triangling, imaging it from different directions. I have found that the linear probes are fantastic for procedural guidance, but that the phased array probes provide you, like the cardiac style probes, aren't as good for anatomy, but they provide better imaging of, better reflections off the catheter. I don't know. What do the rest of you guys think?
I think that's spot on. All your pictures were with linear probes and they're beautiful, but you can use a phased array probe, especially to like ascertain catheter tip position. And like one of the things that we found early on is like looking subcostally and trying to look up, like right at the insertion of the ductus venosus, which you did. It's more challenging to like localize the tip. If you like go slightly parasternal, very low, and look directly down, you often get a better image of the catheter tip position right in that like RA IVC junction where you want to be. So that's sometimes helpful.
Yeah. And to speak to changing probes, because that came up, in my institution, we have an ALS team that does the procedures. So they place the umbilical lines and only call me over when they're struggling. And so my experience has actually been to do it as the unsterile person under the drapes, which gives me the flexibility to switch between the linear probe and the phased array when I'm trying to troubleshoot and trying to find my optimal views. And with the phased array, again, there are more views that you can use, including short axis if you want better view of the cable adrial junction as opposed to just the abdominal views.
I have to agree. I think the phase array is what we usually reach for when we are having trouble.
Great, thank you guys. So this next question is a two-parter. Practically, how long does it take to rescue a malpositioned line? And do you recommend using ultrasound for all umbilical line placements or only when after blind placement fails?
I think it depends on your everything takes practice. I don't place a UV without ultrasound anymore because it takes me the only difference is that I drape a probe cover. Otherwise, I'm doing everything the same and bring the ultrasound machine over. So I want that in case and now if I put the catheter in and if I start to put the catheter in and before I can even find it with my ultrasound probe, it's into 10 and I look and say, whoa, all right. I mean, that does sometimes happen. But like, I don't see any, for me, there's, I use it all the time. It does take, and then the amount of time it takes is the amount of time it takes, right? I think there is a learning curve and there is a time investment. I think for me, I'm faster placing them now with them without. I think at the start that was definitely not the case, and I was pretty committed to figuring this out. And so there were times where I would get it in a few minutes, and there were times where I'd sit there for an hour or more trying to get it to go. But and so you want to be careful not to, belabor or prolong a procedure. But I don't think trying to, do your imaging, but in my experience, it doesn't really do that because the number of times I've seen a kid, it depends what your fallback position is too. The number of times I've seen a kid delayed in the delivery room because they were struggling with line placement, like that happens all the time, right? And so once you're facile with the imaging, it doesn't allow, you're still going to either get it or not get it. It doesn't add that much time in my opinion, or it adds as much time as you allow it to add. And as much time as you have, you can obviously spend. I don't know, that's sort of a circuitous answer. I think we should move towards using them just like draping the probe cover and having it in case you need it, because but you can you can cut down on the time that it takes by spending, a few minutes walking around your unit and getting imaging lines that are already in situ so that you get comfortable with it. And then just be okay being frustrated the first couple times you do it. Then the learning, I don't know, Courtney or Jenny, what do you think?
I think it's two different skills. I think the dynamic use and like localizing the catheter in the liver or in the umbilical. One of the things I think that's been easier like to teach is pulling it back to the umbilical recess, but you could even find with a phased array probe and like seeing the tip there and then following it through as you advance. And oftentimes like we found like flushing, we know that there's this like trick to flush in advance, but you can actually see the ductus venosus like open up wide, and certainly the smaller catheter that's like a little bit harder skill to acquire than like tip localization. So we always use ultrasound to identify the catheter tip position in our unit now, and that's like a very teachable skill to trainees or practitioners and translatable. If they don't find it there, they'll call for help in terms of like the dynamic insertion, because that I think not everyone has like acquired or mastered, certainly not in our unit.
And I also have to second the institution dependent situation, and because it really depends on the number of people who are proficient at the skill. At our site, we really only have 2 people who are proficient at line placement, and one of us a little bit more comfortable at the dynamic placement than just checking position. So it's an emerging field. I too would love to see ultrasound used in every procedure ever, but it's a moving target right now.
Yeah, I agree with all the above. I think we started out as the same thing, identification of UVC tip, and now moving on to the next phase, which Ben has talked about, using ultrasound for every insertion. But at our institution, we are starting small with trained providers who are present at the time and keeping track of all that participants are asking and concerned about, time it takes, and adverse events, for example, temperature in a small baby who's an isolate, those sorts of things. So we are going to be starting this small scale and move forward with it.
Yeah, I think that makes sense. Temperature in the preemies is definitely a bigger issue than it is in the full-term kids. So yeah, no, I agree. It definitely starts small with what people are comfortable with. Pretty quickly you can get to a point where you can watch the catheter go in. If you can just get that view, even if a baby doesn't have a catheter, if you can just get that view that's slightly off axis sagittal where you see the structures, then you can see the catheter come in and out and sort of make its way through. And then after that, you can start to manipulate the anatomy. It does take a little bit of time, but I think you got to kind of give yourself a time limit. And the other question is like, what's your fallback position? If your fallback position is I have people here 24 hours a day who can place a pick super easily, then maybe you don't belabor it. There are a lot of hospitals where that's not the case. And if you need the access, then maybe it's worth, additional time investment.
Thank you, guys. So this next question is specifically about the CDH population. Do you have any experience using ultrasound in infants with CDH to place central UVCs?
Courtney, if you want to.
Maybe Tasneem, but I mean, we do use it, and it's helpful because it never looks right on X-ray, and you can clearly see if it's in the IVCRA junction with ultrasound, and it can look all sorts of wacky places on X-ray.
Now, we have used ultrasound for UVC and CDH population in a small number of babies so far. Our fallback position is to insert PIC within the first 24 hours.
Yeah, I think there are certain populations where this is hard. The CDH population for sure. I mean, the liver's in all sorts of weird places, and then in the for us in the cardiac ICU, the heterotaxy population is another super difficult population because the liver is, all sorts of abnormal. And we've been able to use ultrasound to triage whether we're going to do, you can look by ultrasound and say, oh, this is a heterotaxy baby, but that looks doable. Or I have no idea how we're going to do that. And then, bail to something else. So it's been helpful for that.
Great. I know we're right around 3 o'clock. If anybody has to jump off, we completely understand. We'll ask 1 or 2 more questions, but we do want to be respectful of everyone's time. So this next question is, do you still use X-ray to confirm position if your ultrasound showed correct placement? And if not, how did you convince division leadership to forego the X-rays?
Yeah, I'm not going to die on that hill. It's our institutional standard to have a radiograph for confirming line location, central line location, PICs, UVs, and so we just do it. But so we continue to do that as confirmatory. Occasionally, the line's deeper than we thought, so I'm glad I got it, because sometimes the tip does get lost in the RA, I find. And I tend to lean towards putting them in a little bit deeper than I think I have to if I'm really not sure, because if I'm going to the trouble to do this, then right, I want to make sure it's in. But I think institutionally, like I've not tried to convince people. We do that we don't need any X-rays, but what we have done is not. We certainly have avoided the phenomenon where, okay, it's in at 9. Is it right? Nope, it's in the right portal vein. It's in it. Okay, try again. It's in at 9. Is it right? Nope, it's still in the right portal vein. And like take 7 X-rays. That we don't do. We just do the procedure and then confirm once at the end.
I do have to say, from a medical legal standpoint, be careful about using your ultrasound as your sole diagnostic tool for saying that you are in the correct position. Until we have better guidelines for credentialing, it is probably safer to at least have one film. But I agree with Ben. I think the use of ultrasound can greatly cut down on the number of serial films you need to do on placement. And literature has definitely shown not only reduction in time of total time needed for placement, but also decreased number of radiographs and decreased radiation exposure for these infants.
Great. Thank you, guys. So this will be our final question for UAC. This is a question about UACs using POCUS. Do you have a standard that you use beyond just being above the diaphragm? For example, on X-ray, we aim for the tip at the level of T7 to 8. But as we can be more accurate with ultrasound, would it be feasible to aim for 1 or 2 vertebral bodies above the diaphragm while scanning?
Yeah, this is something that Courtney and I have talked a fair amount about. Courtney, do you want to fill that one?
Yeah, I mean, we aim for, you sort of have, as Ben alluded to, like sometimes you have to take it from multiple views. So like subcostally, you can get the takeoff of the like celiac plexus and then see the catheter running up the aorta, but not truly the tip. Unless you go sort of parasternal, then you can look down and localize the tip pretty easily. And we just aim for above the diaphragm and right behind the heart, which probably is 2 or 3 vertebral bodies like above the diaphragm, although I don't think, I've not counted it that way. It's just like right behind the atria that's laying right there. The other thing we notice sometimes in small babies is like the X-ray landmarks, even when they're correct, like Ben pointed out, the tip can often be very close to sort of the arch or the PDA takeoff or the like left subclavian, and it like is based on the X-ray landmarks that we see in an appropriate position, but on ultrasound seems like not where we would want it to be, too high, and we've pulled it back. So we found some utility in that population as like an advantage over like aiming for the lower version of those landmarks than the higher ones if you're using X-ray alone.
Yeah, for sure. I would definitely agree with that. I mean, there's definitely times where, I would always prefer a high UA than a low UA, and at least in our cardiac kids. And so, you have those catheters that are a little bit lower than you want, and people start asking the questions, well, is it fine where it is, or do I need to pull it down to the lumbar, location? And if I can look with ultrasound and I can see it's, above the diaphragm, clear of the vessels, then it's, even if it's at T9.5 or whatever, like it's good enough. If it's because, you've addressed the things that the X-ray is supposed to help you address. If it's sitting right next to the celiac, or it's not above the diaphragm, sometimes you can image the vessels very easily. Sometimes it's a little harder, but like you can usually see them. Even if your ultrasound skills aren't, yet at the place where you can say, oh yeah, there's the celiac, there's the SMA, and so on. Like if it's below the diaphragm, I'll usually pull it back. If it's at least at or just above the diaphragm, I usually feel comfortable, leaving it where it is. I don't know. Courtney, do you agree with that?
Agree. Yeah. The whole point of the landmarks is to guesstimate where all those things are, and with ultrasound, you can see where all those things are. So.
Right.
Great. Thank you guys so much. Thank you to our speaker and panelists for this wonderful discussion. And thank you to everyone who joined us. Again, this webinar has been recorded and it will be uploaded to the Collaborative's website. That website is located in the chat and on the screen is www.neopocuscollab.com. If you're interested in receiving communication about any future educational opportunities that are offered through the Collaborative, subscribe with your email at the Collaborative website. Thank you guys, and we hope to see you at our next webinar.
Thanks, everybody. I added the link to the videos just there in the Q&A if that helps.
Oh, perfect.
And they're also on the Twitter feed in case they were choppy during the during the presentation.
Great. Thank you so much.
Thanks, everyone.